We're talking about growth hormone problem, okay? Growth hormone, gigantism, and acromegaly. One is before the adolescence and one is after adolescence. Gigantism in adult and acromegaly if in child case, and gigantism in adult. Okay. So growth hormone access, you can use somatostatin from outside. The somatostatin or somatostatin analog of octreotide. This octreotide is somatostatin. It works against growth hormone. The acromegaly patient and gigantism patient have a high level of growth hormone. They have some problem. One thing they develop diabetes also because growth hormone increase the level of glucose. Another issue, they die due to heart problem. Heart cardiac failure is the cause of death in acromegaly and gigantism patient. Okay. So we can use octreotide to decrease the activity of the growth hormone. If we know the patient have, like the child is growing very much faster and the height is according to the age is not good, is more high, okay? So we can access to control the growth hormone level, growth hormone very high, we can use octreotide. Octreotide suppress all the actions of growth hormone, okay? Octreotide, we already know the octreotide used in GIT, esophageal varices. Octreotide were used in carcinoid syndrome. Okay. Octreotide were used in esophageal varices. Octreotide were used in carcinoid syndrome. Octreotide were used in GIT related tumors. Okay. So octreotide were also used in acromegaly and gigantism case octreotide. Another drug we use pegvisomant. Pegvisomant. Okay. What is pegvisomant? Pegvisomant is growth hormone receptor blocking a receptor inhibitor. Growth hormone receptor antagonist. Okay. Growth hormone receptor antagonist. Pegvisomant. Understand? So we can use opioid. We can use pegvisomant in case of acromegaly and gigantism. If the growth hormone level is low in case of dwarfism, so we can use from outside synthetic growth hormone. Okay, so you can use growth hormone if your growth hormone deficiency, the baby is not growing according to the age. It's a, for endocrinologist, the mother went to endocrinologist, have that issue. First, pediatrician have this issue, ask about diet question, everything is okay, but still baby is not going well. Refer to endocrinologist, then that pediatrician refer, they refer mother, take him or her like to endocrinologist. Then endocrinologist do the test, perform the test, assess the growth hormone level or growth hormone was low. So it's a growth hormone little according to normal level, so then that endocrinologist give what growth hormone, just synthetic growth hormone. Okay, in case of dwarfism, if diagnosed early, if diagnosed early this situation, the growth is stunted, short stature, so we can control it. Okay, we give growth hormone from outside. If growth hormone very high, octreotide and pegvisomant. Understand? For acromegaly and gigantism. If growth hormone is low, you can use growth hormone from outside. Okay, now move on. Next one, the next issue related with has to deal with in data pituitary prolactin. Prolactin. Okay. Now, prolactin problem, the most common tumor inside the pituitary is related with prolactin. Second most common related with growth hormone. So prolactin level increase, prolactinoma, prolactinoma. So very high level of prolactin in blood. Prolactinemia. Prolactinemia means high level of prolactin in blood. So if the because the tumor of the pituitary. And what happened the female and the male? Is a gonadotropin releasing hormone decrease. FSH and LH will decrease. So in both sexes, male and female, what happens? Infertility decrease libido, and in female especially amenorrhea and galactorrhea is a self discharge of milk. Galactorrhea, amenorrhea, infertility, decrease. So these are the problem. Okay, in the male you can add here gynecomastia. Gyneco. This in male, gynecomastia in male. Infertility in both, decreased libido in both, amenorrhea, galactorrhea in female, and in male, gynecomastia. So these are the problems related with prolactin. If prolactin is high, prolactin only produced at the time of lactation. After giving birth, then prolactin comes. Yeah. So this prolactin help for milk production, and oxytocin help for milk ejection. So this prolactin is high at the time of lactation by naturally LH and FSH low. If some problem with the prolactin very high, this prolactin can suppress LH and FSH, can disturb the so LH and FSH act on gonads, testes and ovaries, and then they produce sperm and ovum, and they release hormone testosterone, they release hormone estrogen. Okay, so this everything is going down because you decrease the GnRH by increasing prolactin. So prolactin causing what? Hypogonadism. Hypogonadism. Understand? They suppress the gonadotropin releasing hormone, decrease LH, decrease FSH, decrease gonadotropin releasing hormone, decrease testosterone, clear? Decrease testosterone, decrease estrogen, decrease progesterone. So every hormone is low. It lead to infertility in both. Okay, decreased libido, amenorrhea, galactorrhea, and gynecomastia. The basic problem was the tumor inside the lactotroph pituitary. In the pituitary, we have lactotroph is producing prolactin. The important thing here, so we can perform the surgery because a tumor, yeah. So we need to remove this tumor. But the prolactin is already very high, so we can use prolactin inhibitory hormone. What is prolactin inhibitory hormone? Prolactin inhibitory hormone, the name is dopamine. It's a neurotransmitter. Dopamine from the hypothalamus suppress the prolactin level. This prolactin inhibitory hormone is the dopamine. Okay. So if you release dopamine, if you stimulate dopamine, you can control prolactin. So we use drugs related with dopamine. Dopamine agonist. You remember? Do you remember any famous drug for prolactinoma? Bromocriptine. Bromocriptine. Cabergoline. Caber. What are these drugs? Are gold derivative done in Parkinson disease? Yeah. So these drugs we use to control the prolactin level. Yeah. Bromocriptine and cabergoline. These drugs they increase activity of dopamine. So if you increase activity of dopamine in hypothalamus, you able to suppress the prolactin from lactotroph. Prolactin going down. This is a therapy. Medical therapy, bromocriptine and cabergoline. How about the surgical therapy? We need surgery because it's a tumor. Okay, we need surgery because tumor. Sphenoethmoidal surgery. Sphenoethmoidal. Sphenoethmoidal surgery. This is a phenide bone, is a ethmoid bone. Okay, this access through the nose. A surgical procedure just to get access to pituitary gland. Okay, it's a sphenoethmoidal surgery to remove the tumor, prolactin tumor. Understand? The main therapy is the surgery, just removal of the tumor. Otherwise, the patient can be blind easily. Bite and borrow hemianopia, it destroy opticals, pituitary tumor damage opticals, optic nerve. The medical therapy, bromocriptine and gabapentin. Understand this about prolactinoma. Just unclear? Bromocriptine and gabapentin we use for prolactinoma, prolactinemia. Okay, now move on. Another hormone problem, ADH and oxytocin. The ADH and oxytocin disease, posterior pituitary. Now I move on posterior pituitary. Posterior pituitary releasing ADH. If ADH is very high, ADH is low. If ADH is very high, why ADH is very high? If the ADH is very high, for some tumor they release ADH. If the in your body, if ADH is very high, what happens? More absorption. Yeah. If ADH is no ADH. If no ADH, it leads to the two conditions. One is diabetes insipidus. Diabetes insipidus. And this one is your SI-ADH. Understand? Very high level of ADH. If you have very high level of ADH, so then here we need what type of drugs here? We need ADH antagonist because very high level of ADH antagonist. What's going on in your body if you have very high level of ADH? Kidney absorb too much water. Yeah, water increase. Water increase. What happens inside your body? Hypervolemia. Hypervolemia. Blood pressure increase. Okay, because the urine is not going outside. And when you increase the absorption of just water, how about the osmolarity? Osmolarity will decrease. You just putting water. How what happened with the sodium? Decrease because just absorb water, ADH hormone from the kidney, just absorb from the kidney, just absorb water, not sodium. Yeah. So from collecting duct, just absorb water. So water more inside your body, hypervolemia, increased blood pressure. And what happens inside the blood? Osmolarity decrease. Or osmolarity decrease means because you blocking you just absorb water is known as dilution. It lead to dilution. And when there dilution, what happens with solute? Sodium will be less because just putting water inside. Yeah. So hyponatremia. This hyponatremia, what happened with urine? Water going out, urine decrease because very high level of ADH. Okay, urine decrease. What happened with osmolarity of urine? Osmolarity of urine. Osmolarity of urine very high, very concentrated urine because you not allow water going outside. Okay, you not allow water going outside. So it's your SIADH. Understand? It's your SIADH. Severe inappropriate ADH. Very high level of ADH. So what you need to do here, you must block ADH hormone. Yeah. So I want to use here ADH receptor antagonist. ADH receptor antagonist. Clear? ADH receptor antagonist. ADH receptor antagonist, so we use for SIADH. ADH receptor antagonist. Clear? So ADH receptor antagonist. What are the ADH receptor antagonists? The one antibiotic, demiclocycline. Demiclocycline. This drug belongs from, it's a tetracycline family. It's a antibiotic. Okay, it belongs to tetracycline. It's known as demiclocycline. Demiclocycline is working against ADH, block the ADH receptor. Okay, number one, demiclocycline. Number one, demiclocycline. The other drugs, second one, oniveptan. Oniveptan. Oniveptan and tolvaptan. These are new one. Tolvaptan, conivaptan. Demiclocycline, onivaptan, and tolvaptan. And these drugs, they block ADH receptors. These are the ADH receptor antagonists. So they not allow ADH to work. Understand? They block the receptor. They block the receptor. What happened in SIADH? Some pathological condition, maybe some cancer inside the body, they're releasing cancer cells, squamous cell cancer like this. Okay, the small cell carcinoma release ACTH, release small cell carcinoma also release ADH. So also release ADH. So releasing ADH too high. If ADH too high, so ADH doing what? Water absorption, hypervolemia, more blood pressure, osmolarity decrease. If osmolarity decrease, what happen with the cell? Cell can swell. Okay, if you know, if your body osmolarity less, if you're putting the cell in hypotonic solution, what happen with the cell? Cell swell, brain cell swelling. Okay, the hallmark of SIADH is a hyponatremia. The important change in our body is hyponatremia because you're putting water inside the body and sodium is less now. Delusional is known as delusional hyponatremia. You can block the action of ADH on collecting duct, not allow this ADH to work on the kidney. Understand? So we can use demiclocycline, oniveptan, and tolvaptan. Demiclocycline, oniveptan, and tolvaptan. Understand? So what are these? These are the ADH receptor antagonists. ADH receptor antagonists. Okay. Now move on this side. Just now we finished. We have very high level of ADH. Okay. Now we talk about if you have a little level of ADH. ADH is low. If the ADH is low, ADH is low. One thing. Another problem. ADH not working on nephron. Okay. So this condition known as diabetes insipidus. ADH is not working properly. Maybe ADH is low or ADH is low is known as central diabetes insipidus. Okay, it's a central diabetes insipidus. If ADH is not working properly, it's known as nephrogenic diabetes insipidus. There are two types. Okay. If ADH is not coming from the pituitary, maybe pituitary is destroyed. It's your central diabetes insipidus because ADH is not there. ADH is not there. So what we can use? We can use ADH in the form of desmopressin. We can use ADH in the form of desmopressin. Clear? In the form of desmopressin. What is desmopressin? Is just ADH, synthetic ADH. If the ADH is already there but is not working properly, For this condition, we can use thiazide diuretics. Thiazide diuretics for diabetes insipidus. Another thiazide diuretic. So why nephrogenic diabetes insipidus? Nephrogenic diabetes, maybe some drug is not allowed. For example, if you're using lithium causing diabetes insipidus, we must stop lithium. If we're using inside the patient, just now clear that demiclocycline is antibiotic tetracycline for any infection using demiclocycline. Demiclocycline also not allow ADH to work properly. Yeah. So demiclocycline and lithium, they causing what diabetes insipidus. So you must stop the use. Stop these drugs, lithium, for bipolar disorder, demiclocycline for any type of infection we use. Okay, we must stop the medication who causing diabetes insipidus. Understand? And for the treatment, we can use thiazide diuretics. Thiazide diuretics. So in this case, ADH is not working. The kidney, what happened inside the diabetes insipidus? Because ADH is not working. If ADH is not working, what happened? Can you absorb water? No. Water going out. When water going out, what happens? Hypovolemia. Water loss, yeah? Hypovolemia. Blood pressure a bit low. Okay. Next, what happened with osmolarity? Because you're losing water and your body fluid become concentrated. And what happened with the sodium? Because you're losing water. If you're losing water, sodium according to water become high. So here is your hypernatremia. Okay. In SIADH, hypernatremia. And what the change in urine? Or frequent urine, polyuria, poly, frequent urination, polyuria. How about the urine osmolarity? Urine very dilute urine because the kidney not absorb water. Yeah, polyuria, very dilute urine. So because of polyuria, we having very high level of osmolarity here. Okay, so osmolarity very high. This person again drinking a lot of water, polydipsia, excessive thirst, polyuria and polydipsia, polyuria and just drinking water, again going to WC, polyuria, polydipsia, because ADH hormone is not absorbing water from collecting duct. Understand? ADH hormone is not absorbing water from collecting duct. What is the reason? Maybe ADH hormone is absent. If totally absent, it's a disease here, disease related with pituitary. Okay, if totally absent, then we can use desmopressin. Okay, we don't know, the patient just have this complaint, polyuria, polydipsia. What's the problem here? What's the problem here? It may be central, it may be nephrogenic diabetes insipidus. Okay, so first we give desmopressin to patient, and this also help to diagnose or it's a nephrogenic or central. If nephrogenic, because ADH is not working, yeah, ADH is not working. In this patient, if we check the ADH level also high, ADH high. Here you can see ADH is low. Yeah. So when you give the desmopressin, the patient, if patient write sentence here, after giving desmopressin, if patient responds, the polyuria a bit control. Yeah. Polyuria a bit control. Understand? A polyuria bit control. In diabetes insipidus, polyuria and polydipsia is a problem here. Okay. Polyuria and polydipsia. If that polyuria is controlled, then it means it's a central. If the patient after giving desmopressin still have the same problem, again polyuria, polydipsia, still urine quantity is too much, okay, diluted urine there, it means the problem is not with the pituitary. ADH is already there. If ADH is not working on the nephron, you're giving from outside, already inside the patient we have a lot of ADH there, but that ADH is not working properly. Understand? Not working properly on the nephron. So no response is mean nephrogenic diabetes insipidus. After giving desmopressin, if patient not give response, it mean nephrogenic diabetes insipidus. If patient give response, the polyuria is controlled by desmopressin. It was a central one. Okay, it's a central one. What treatment of nephrogenic? What is the cause for nephrogenic? Nephrogenic diabetes insipidus. We're using lithium. We're using domiclocycline for infection and lithium for bipolar disorder. These two drugs they not allow ADH to work properly. So these two drugs they causing diabetes insipidus, nephrogenic diabetes insipidus. We must stop the using of these drugs. Okay. Some patients with chronic renal failure also have this problem. Chronic renal failure because of hypertrophy and many nephron damage. Okay, the ADH is not working properly in the damaged kidney. The in chronic renal failure also the patient have sometimes patient have diabetes insipidus problem. Okay, the therapy for diabetes insipidus here is a thiazide diuretic. We can use thiazide diuretic. Done. About ADH clear? About ADH hormone. First we finish this SIADH. Okay, a very high level of ADH. If SIADH for treatment, we need to give ADH antagonist, demiclocycline and conveptan and tolvaptan. Okay, you can see the difference here. More water, hypervolemia, increased BP, decreased osmolarity because dilution. Decreased sodium is a hypo, there is hyponatremia. Okay, it's a hyponatremia. And the urine osmolarity is going up, concentrated urine flow. The opposite happen in diabetes insipidus. In diabetes insipidus, what's the problem? No water absorption, decreased water, hypovolemia, low blood pressure, okay, osmolarity high, so that's why the patient thrust center is activated, okay. And in the sodium, what happens in sodium? Sodium also high because no water inside the body, hyponatremia. And the urine, polyuria, this urine also very diluted urine. Understand? Urine also very diluted urine. So how you can treat? First, we give desmopressin. If patient give response to desmopressin, it means central diabetes insipidus. You can continue therapy with desmopressin. If patient not give you response to desmopressin, then you think about what medication patient is using. It may be the peripheral issue there, okay? It may be the problem in the kidney. The patient with chronic renal failure, patient may be on therapy of the lithium, patient may be using demiclocycline. You need to stop medication if the medication causing diabetes insipidus, okay? So what the therapy for diabetes insipidus? So we can use thiazide diuretic. Thiazide diuretic for diabetes insipidus, okay? The next hormone, oxytocin. Oxytocin. Oxytocin we can use from outside for what purpose? Oxytocin we use to induce labor, induction of labor, induction of if labor a bit delay for uterus contraction. The function of oxytocin help in labor. Okay, induction of labor. If after delivery, sometime what happen after delivery, postpartum hemorrhage. When placenta separated from the uterus after delivery, the first delivery of the baby, then after the delivery of the baby, then delivery of the placenta. The placenta separate from uterine wall, so that time sometimes artery can bleed too much. To control postpartum bleeding, we inject again oxytocin. Okay, to control bleed after birth. PPH means P for post, P for partum. Partum, the word is related with delivery, okay? Postpartum hemorrhage. And if the mother is pregnant and during pregnancy, the like 25 weeks, 30 weeks, okay, not yet complete pregnancy, and now mother, the pregnant lady have bleeding while pregnancy. That's known as antenatal APH, okay? It's antepartum hemorrhage, APH. APH is have they have different causes. APH is for gynecology terminology. Antepartum hemorrhage mean before delivery the bleeding, PV bleeding, parvaginal bleeding. And postpartum hemorrhage after delivery. Understand the difference between postpartum and antepartum. The postpartum bleed, to control bleed, we can use oxytocin to control bleed. To control bleed. Okay. If the mother is not lactating after birth, mother not lactating, no lactation, no lactation. It's mean no milk ejection after birth, no milk. Failure to eject the milk, so you can use oxytocin. If you remember this pathological term, Sheehan syndrome. This happen in during the pregnancy. Pituitary size increase if the mother have PPH, postpartum hemorrhage. The blood supply to pituitary gland decrease and ischemic necrosis of the pituitary gland during pregnancy. This happen with the pituitary gland. Okay, this happen. How we know the mother have this syndrome? The mother fail to lactate. Okay, mother fail to lactate because no prolactin, no oxytocin there, no prolactin, no oxytocin. If fail to lactate, we can use oxytocin. I just giving a the idea about the Sheehan syndrome or Sheehan syndrome. Sheehan syndrome, the pituitary size increase during pregnancy because the baby also using hormones, and this Sheehan syndrome. If the mother at the time of delivery have bleeding problem like postpartum hemorrhage there, okay, so the blood supply to pituitary is going to decrease and pituitary undergo necrosis. Pituitary destroyed, okay? The no more prolactin release. If no prolactin, no milk production, so failure to lactate. Mother failed to lactate. The doctor must think about Sheehan syndrome if mother failed to lactate after delivery, okay? Not able to feed. Understand? This about Sheehan syndrome. So we can, these are the uses related with oxytocin. This about the pituitary, okay? The next things left, we will discuss thyroid in detail, and the two things left, thyroid and endocrine. The endocrine part, the diabetes, okay, pancreas, thyroid and pancreas. Tomorrow, inshallah, we will discuss about diabetes drugs, and thyroid drugs.
Okay, sir.
Enough for this
Okay, sir.
class.
Thank you so much.
Yes, you. Assalamu alaikum.
Waalaikumsalam.